We shall proceed with our next session now. Welcome, sir.
Okay. Let me please call to the stage Bob Kocher from McKinsey & Company, Ann Jacobson, the Executive Director of the Joint Commission International, and Kent Thiry, the CEO of DaVita, please. I'd like to introduce Kent, who's going to works closely with the Obama administration and many others in the United States on improving health care. Sir.
So you're Mr. Bob Kocher?
Yes, Bob Kocher.
So I'll just upload your presentation document because I've just heard that you have changed your presentation.
Yeah, patient safety. Yes.
Presentation that you gave me, I have that one.
I have both of them. No, I gave it. Well, I have one, but it's encrypted. I have one on my phone. Otherwise, it's I have mine has a password.
Where is it?
Here's
Where is it?
Here you go.
Yeah.
There's a password.
Chick.
It has to type in the code.
Hello, chick, chick. Hello, chick, chick. Hello, chick, chick. Hello, hello.
Good afternoon. Can I start? Good afternoon.
Hello, chick.
My name is Bob Kocher.
Hello, chick. Hello.
Okay, thank you. Good afternoon. My name is Bob
Hello, chick.
Kocher, and it is wonderful to get to come to Hyderabad. I come here after working 2 years in the White House in the Obama administration, where I led the U.S. healthcare reform work and our work to transform the healthcare system to be higher quality, safer, and in some ways, perhaps more like some of the hospitals in India. When President Obama talks about India, I think it's exciting that the competition has moved to a global stage. It helps us push ourselves to be better in the United States, and I think it helps India push itself also to imagine bigger things. I'm struck by how India is at a moment where you can actually leapfrog others in what you're doing in the health system. In fact, when I land here on the plane, you can practically see the GDP being created in India and driving the world. And it's an amazing thing to see. Amazing things are happening here. I thank the Apollo Hospitals, the Reddy family for inspiring us. I thank all of you for coming to a conference to talk about patient safety and IT. There's no question that IT and patient safety are inexplicably linked, and that we're at a point in time in healthcare where we can change the way we think about healthcare and IT and patient safety to fundamentally change what we deliver to patients, to improve patients, and to reduce costs. I want to frame my remarks around 3 questions today. The first one is, patient safety has thought a lot about avoiding harm, but much less about optimizing the outcomes. The second point I want to make is, why is more data being used today in other markets, not healthcare? Perhaps there's no place where data is more important than healthcare, and knowledge more important to bring to bear at the point of patient care. So why is it that more data is used to predict how you're going to purchase your equipment and which cell phone you'll buy than to which treatment your doctor should choose for your treatment? And finally, why isn't quality the product that's delivered in healthcare? In healthcare, we spend a lot of time talking about surgeries and tests and procedures and access to doctors, but really the product should be the quality of outcome that you get, not sort of the access to technology that we so much focus on offering. Patient safety has for a long time focused on avoiding complications like ventilator-acquired pneumonia, pressure ulcers, catheter infections. A lot of work goes into fall prevention, avoiding urinary tract infections, medication errors we heard much about this morning, and right now in the U.S., much work also around readmissions. But really, we should change what we think when we think about patient safety to talk about reliably achieving the best outcome for the patient. And that's not an outcome for a population, it should be an outcome for a patient. It should be a discussion with the patient about what they should expect, what you can deliver, and ideally something that you can guarantee. The patient should perhaps not pay more for complications, and the hospital should perhaps bear some risk for what happens after the hospital. When you talk about data, what you see is that data has transformed virtually every other sector of the economy in the world. If you think back 20 years to cars, they were as unreliable as hospitals, but they've made great strides. In fact, when a car breaks down, the diagnostic personalization to tell you what's wrong with that car is much more specific than what we're using in healthcare. And prices have fallen. In healthcare, we need to emulate some of these ideas around personalization, around data transforming the process, and around falling prices. If you look at the retail world, what you see is that the ability to predict what people will buy and what will influence them has changed the way in which retailers work. Crowdsourcing has changed the way people select products. Well, in healthcare, patient-derived data can change the way clinicians think about how care can be delivered and how to make adherence work better. There's no question that predictive modeling can predict patients who need more intensive care, different treatments, more aggressive goals, and change the way the care is delivered to them. There's also no question that at the point of care, having predictive modeling to say what is the next best question to ask mathematically to understand and reduce probabilities is the right way to think about bringing data to the point of care. I know from my medical training that there's more that I've forgotten than I remember. And at the point of care, having technology to help the physician and the care team determine the right treatment at the right time for that patient and the right goal for them will do a lot to avoid the errors of omission, commission, and complications. And finally, on personalization, the healthcare is not a product, it's a personal choice and decision. And so being able to personalize the care and approaches to meet a patient's wishes, the family's wishes, is something that's been done in every other sector that, again, we need to bring to healthcare. I believe that you're at a point in time, particularly in India, but the whole world, where healthcare is not going to just evolve, but it needs to actually transform, which is the goal of this conference. There's 4 transformations that need to happen, and IT is going to be front and center in each of them. The first one is labor productivity. Healthcare uses too much labor at too high cost and is far too reliant on the in-person encounter. While India is blessed today with lower cost, high-skill labor, that advantage is going to dissipate every day. And so labor productivity is fundamental. The second one is data liquidity and transparency. You cannot have a marketplace where information is totally asymmetric. You cannot have good patient care where information is also asymmetric. There has to be data liquidity across providers, across patients, that allows one to benefit from what's happened before, to monitor outcomes, and to let there be a marketplace that actually values quality and competes on that basis. The next one is selling years of life, years of health rather than discrete episodes of care. A major mistake we make in the U.S. is that we pay per activity in healthcare, not for the outcome. As part of the Obama administration reforms that I worked on, we're changing the way we pay to begin paying for years of life or outcomes of care and bundling the inpatient and outpatient care together. I urge you to think about how to pay for an outcome and not everything along the way. It is only in that way that you can have data transform the care and also use resources judiciously. The last point to make is that there has to be a transformation around prices. Unlike the rest of the economy in the world, healthcare prices have relentlessly gone up with the improvement of technology, not fallen. Why is that? That's due partly to absence of labor productivity, partly due to inappropriate use, and a lot due to not harnessing data to predict who will benefit from the technology so that we can use technology in ways that improve care and reduce costs. So why is it quality product? Well, a couple reasons I'll leave you with. One is there has to be a reorientation of the market. In most other industries where quality becomes the basis of competition, there's an industry that has to search for a new way to demonstrate value and price value. So an industry search for ROI, return on investment. The second is you have to create a marketplace that can use the data. You have to change the nature of consumer demand such that consumers shop and choose on the basis of quality, safety, and value. That requires data. That requires tools. That requires undoubtedly the media and others helping to raise awareness to this issue. And finally, government needs to help on creating some of the shocks or creating some of the markets. And so whether it's standards for data sharing or interoperability, or whether it's a crisis related to safety or burden of disease, you have to have something to tip the market to start caring about data. And then you need some incentives to make it work. In the U.S., we put a bunch of economic incentives in to turbocharge the system and to drive towards integration and a market of data transparency, and that spurred a bunch of innovation. Innovation like what's happening here in India. Many, many companies that are using data to help consumers get better care, shop better, help providers be far more reliable, and change how we think about what care is. People are now being able to buy guarantees of their care, warranties on their treatments. They're able to buy outcomes, not process. So there's a fundamental way to think differently, and these types of companies that all are based upon data are essential to delivering that. So what's the future? Well, the future looks a little bit more like Google and less like a doctor visit, I think, for how healthcare will be delivered. I think we will have probability-driven questioning. We will have this personalization of the treatment goals and outcomes, companion tests to predict which therapies are best. We will have teams of providers, and we'll be far less focused on the hospital. The hospital will be a small part of a big system, not the focal point of the system, with most of the care happening outside of hospitals, in clinics, and in subacute facilities that make hospitals for the sickest and particularly focused around the ICU. And how will we do that? We'll be massively more focused on achieving the clinical goals, titrating the treatments, and working with patients to deliver against exactly what we've laid out in the front, and probably paying on the basis of achieving those outcomes. So with that, I want to thank you for your time and attention, and hopefully inspire you to make Americans even more competitive with what you're doing in India. I ask you to try to be more like Apple, Amazon, and Lexus than hospitals. Make your patients both better and richer, and organize around the outcome. Thank you very much.
Thank you, Bob. For those of you who follow the science of innovation, you may have read the book by Clayton Christensen called The Innovator's Prescription. If you haven't, I recommend it to you. One of the things it talks about is the movement of medicine from art to artisanship to science. And a big part of that is moving from towards precision medicine, where we know exactly what's wrong with the patient and therefore we can treat them exactly for what they need in the most efficient way possible. A company called DaVita represents about the best of that in my country, the United States. They are the leaders in our country in taking care of renal issues. I want to introduce Kent Thiry, who is the CEO of the company and who's our special guest. Kent?
First, I just have to say that I've been in healthcare about 30 years, and today was a very exciting day for me because I got to sit with Dr. Reddy, one of the most respected names in the entire globe in healthcare, one of the most respected spirits, one of the most respected sort of healthcare forces of nature. So it'll also save my company money because I was so excited I won't need a plane to fly home. So it was a great treat for me. I looked at the agenda and the attendees for this conference and realized I'm not even qualified to be an attendee, much less a speaker, and so I will be appropriately brief. However, as the CEO of an enterprise that has about 2,500 locations that provide dialysis in America across the entire country, I am one of those who sees a crying need for the application of technology to improve quality, reduce costs, and build in wellness. And so it's in that spirit which I can speak. I will, I guess, preemptively cite two takeaways from this visit to India and my last one, because we want to provide dialysis here in India. We've visited several centers, and one of the most striking insights is that I now feel, and have told my folks back home, that I think we're going to take as many, if not more, ideas from India back to America as the number that will travel in the other direction. And the second is that this country has formidable healthcare challenges, as does mine. One of the really impressive, striking differences is the sense of confidence that this country seems to have, not naively so, but pragmatically so, aggressively so, that you're going to conquer those challenges. And that's something right now in my country that is in many quarters lacking. I do hope that you can avoid some of the mistakes, some of the system architectural type mistakes that have prevented technology from working the same sort of wonder in American healthcare that it's worked in so many other American industries. From a technical point of view, it's easy to talk about interoperability and things like that, but I think one of the root causes beyond that is the way that provider populations, provider segments tend to behave. The absence of a standard definition of performance measures, the absence of standardized methodologies is a real problem. And many times provider groups shoot down any idea that an academic or the government comes up with in order to create dramatically more transparency around these subjects. And I'm reminded of the Winston Churchill quote when he said, "Democracy is the worst possible form of government except for every other." That I think many of my fellow providers need to realize that the only thing worse than most of the proposed transparent public clinical outcome reporting ideas, the only thing worse is not doing any of those ideas at all. And it seems that your country is well along with the help of the technology advances that you're talking about to make that happen and unfold differently here than it has for us. Nonetheless, I will cite a couple things that we have done that we found to be really exciting through the relatively perhaps mundane application of technology that's nonetheless had a big impact on the quality of our patients' lives and in many cases the size of the taxpayers' tax bite. And so I offer these up not as some sort of stunning revelation, but more in the spirit of Confucius, who said, "'Tis better to light a small candle than curse the darkness," and it would be inappropriate for me to just curse some of the transparency darkness that exists in America without talking about a few of the candles. We've established a patient portal on the web for many of our patients, soon all, where they can do things like access their own lab values and receive customized advice for what they should do and customized reminders for what they should do. And the response has been nothing short of spectacular. And so we're going to be doing more and more of that. We established something as simple technologically as something called a diet helper if you're a kidney care patient, and we take care of 130,000 kidney care patients every single week. We do about 20 million treatments a year. And something as simple as trying to cook for yourself and the rest of the family becomes a very significant clinical challenge, separate from what happens in a dialysis center. And so we established this online diet helper tool where you can put in what you're intending to make for yourself, and the software will then respond and tell you how much calcium you're going to be consuming, how much phosphorus you're going to be consuming, help you keep track of cumulatively what you've done over a period of days and weeks. And once again, with this application of existing technologies through a creative new delivery method, we have, without a doubt, dramatically affected the well-being of literally thousands of our patients and received positive feedback far in excess of that which we get for a lot of what we do every day in the center for them. We also do, as many of you do, a lot of wireless remote monitoring from the home in order to track conditions like weight and fluid accumulation. We've also found out that the use of, again, existing technologies to encourage social networking amongst our chronically ill patients leads to a rebirth of compliance energy that can often make a very significant difference in their clinical outcomes. And we can be the facilitator in this way, in a way that no one else can with the normal public websites. We're also developing a customized EHR, and so that a physician who works with us can access it from anywhere they can access the web and acquire data as to what's going on in the vascular access center, in the dialysis center, in their practice, in our integrated pharmacy, all from the web, all from anywhere, providing integrated information from all those different resources. And then the final example I use is these things should start at home. We have 35,000 teammates that take care of those patients, and we now have a health risk assessment tool that dramatically helps encourage more thoughtfulness and remind one to be thoughtful in an interactive way, which the teammate can do from home. So these are 5 or 6 examples of areas where the more creative application of existing technologies, sometimes with a little bit of technological advancement, can do wonders for the actual clinical outcomes on top of all the hard work that we do in our centers every day. So for me, I guess if I had one message that has some chance of being useful, it's to the providers and to those of you who interact with them. And what we hold is that the truth will set us free. That in the end, we cannot expect the government to spend a lot more money. We cannot expect employers to spend a lot more money. We cannot expect consumers to spend a lot more money unless we as providers collectively provide the information that shows that it's well spent. And so the truth will set us free, but the truth can only be discovered and promoted if we collectively promote, standardize, and share in the most transparent fashion all the different clinical performances that we're putting on the table each day. I will wrap up by saying, as an admittedly superficial observer of what's going on here, I'm learning a lot with each successive visit. I think what you are doing and are about to do in terms of dramatically improving health care in India over the next decade is going to provide an equal number or more gifts to the rest of the world. And so I wait in eager anticipation to take some of those home. Thank you very much.
Thank you, Kent. Our last speaker in this session is becoming a favorite of mine. I just found out she's a nurse, and for a long time, my favorites, and if you're doctors, please don't be angry at me, but my favorite professionals in medicine have been nurses. I ran an organization for many years that was chaired by the emergency nurses. But Ann Jacobson has been with the Joint Commission International and its chief for the last 4 years. This is a very important group. Some people think of the Joint Commission as the folks who make sure you don't do bad things. In fact, what they keep doing is raising the bar. And Anne is a passionate advocate, as you may have heard, on patient safety and a variety of other issues. So Anne, please join us.
Computer?
I'll just upload your presentation. Is the one right now?
Yeah. Okay. Well, good afternoon, everybody. And I give you all credit because I'm sure you're very hungry right now, so I will not take too much of your time. But I did want to briefly, and I'm glad that you brought up that I was a nurse, because I wanted to talk about IT in the context of nursing. If we think about the information technology, that information technology needs to be in the context of the environment in which nursing occurs and where patient care is delivered. So what I'm going to mention today, just briefly, is more or less the integration of information technology and facility design, because the two have to mesh. So I'm talking about enhancing access to and use of patient information, as well as enhancing the nurse's efficient work environment and workflow. So first of all, talking about access to patient information and using technology to save nurses time. A couple points here. One is that the patient information that is so important for the nurses to do their work needs to be at the location, at the point of care. The nurse is going to spend less time running around looking for medical records if that technology is located right in the environment where the patient is, where their room, right outside their room. Also, this is going to facilitate communication of information between the nurse and another nurse in the handoff process, or between the nurse and the physician, or the nurse and others. So this whole process of information technology should, and at some point, save time and be more efficient and more effective. Also, in terms of using information and technology to save time, having an accessible physician order entry system is also going to assist the nurse in her work or his work to be able to not spend so much time looking for physician's orders, clarifying physician's orders, and so forth. And the information technology will also facilitate documentation of care. And hopefully the systems can provide a lot of tools and resources to be able to, for instance, identify high-risk patients very quickly, have screening tools or things like that. And then also have other tools and resources as part of that that nurses can use in educating patients and their families. Also, having information accessible and using technology, the presence of bedside computers will allow the patient to be involved in the process of care as well, in terms of being aware of what is going into the patient record and increasing their involvement in care. I already mentioned a computerized physician order entry system is another piece of technology that goes along with the information system. Additionally, an advanced call system and also wireless phones that nurses can use will enhance the care process. And barcoding, I know you're all familiar with that, in using that type of technology with medication administration and patient identification at the point of care. So thinking about some of the principles, if you're merging the concept of designing facilities in the context of information technology, or designing information technology in the context of facility design. In my mind, those two have to fit together. And I know all of you in this audience are interested in information technology, but my request is to consider that information technology in the context of the design in which the caregivers and professionals work. So it's so important that they are involved in any kind of design process, so that you in the design, as the designers, understand their work and what they need to have accessible to them in order to care for patients. And using the methodology of failure mode and effects analysis throughout the design phase, so that it is so that you don't have a process that is implemented that in fact increases risk to patients, because we're all about patient safety, and at the end of the day you want to ensure that the process that's being designed is safe for patients. Also, thinking about the systems, because healthcare has become more about systems than about the individual right now, and you need to figure out the systems that really interface the care of the patient. So I'm talking about systems such as, medication systems, communication systems, care delivery systems. And that would include not only the information technology, but other equipment that will help in reducing errors and providing a safer environment both for the patients, their families, and also for the caregivers. And considering the human factors and the effects of those on the environment in terms of the design. So we're talking about such things as stress, fatigue, pressures that they're under for time, and other physical things such as noise in the environment and temperature. These things have been documented in terms of increasing medication errors when nurses are in an environment where it's noisy and there's many interruptions, and it makes it difficult for them to concentrate on a task that's very specific and detailed. And all of this goes within a context of a culture of safety. So how will the systems work so that individuals have a very easy way of reporting errors? Because we know the more errors that are discovered and reported can be worked on and improved. If we don't know about them, then they will continue to happen and patients may be harmed. And also transparency. And lastly, thinking about the patient and their family in delivering care, considering their point of view and their needs as part of the process. And also groups of patients, because patients are not all the same. So you're talking about what are the systems that need to be developed to work with vulnerable patients. So by vulnerable patients, I mean the frail elderly, children, adolescents, maybe individuals with mental health issues, and so forth. And then what are the elements of their care that are key. For instance, risk assessment, a proactive risk assessment, or risk screening for, and as part of our Joint Commission International Standards, standards become the basis for the process of improving care and safer care. And so looking at the standards as part of your design will help implement those requirements within the context of the information system. So talking about such things as assessment of patients, planning care, documentation of care, discharge planning, these are all involved in the accreditation process and the use of standards to improve care. And really, I feel that as a representative of the nursing profession, it was important for me to be able to communicate to you the importance of the nursing role, because they are the primary caregivers. They are over 50% of the hospital staff, and the first caregiver or professional person that patients contact when they reach the hospital. And so the work that they do is so integral to that patient's safety that it is, from my point of view, really important to consider the context in which the care is given, as well as the equipment and the technology that's used as part of delivering care to patients. Thank you.
Thank you, Ann. We now are supposed to have our lunch break, and I think there's exactly 1 minute before we start up again. So I'm going to award some mementos to these wonderful speakers, but feel free to get up and take a little break. If you didn't get any food, please get some food, and I think they want to start the program up as soon as possible, but I will see you later this afternoon. Thank you for your attention, folks.
Ladies and gentlemen, Mr. David will present the speakers with the mementos. Let us have a round of applause for them, please. Thank you so much. Thank you.